David D'Alessandro, also from the Massachusetts General Hospital.
I want to thank the association and our moderators for the invitation to present this morning. It's really a pleasure to be here. My topic is the Transmedics OCS Heart, and we've now heard all about it, so what do you want to talk about for 15 minutes? No, I thought that Chris and I, because we work together, might have the same slide deck, but it's a little bit different. When we trained for this device, the company gives you the option if you want to work with your perfusionist or someone else, and we, of course, chose to work with a perfusionist. We have a really terrific and collaborative group, and for those of you that are thinking of getting into this, I would highly recommend you have perfusion involved. They just have a knack for this stuff. They're really good at it, and it allows us to sort of focus on separate things. It is a stressful environment, and I'm going to talk about OCS for marginal hearts. When you get into the DCD arena, I think that level of anxiety really goes way, way up. I have no financial disclosures. I will, of course, be talking about the Transmedics system, which is not FDA approved to be used in heart transplantation in this country. So as we heard a couple of talks ago, we just celebrated our 50th anniversary of heart transplantation as a clinical entity. And while this has become and remains the gold standard therapy for end-stage heart failure, the real problem is this one, and we talk about an organ shortage. It's really not an organ shortage. If you think about it, it's not a good thing to have too many organ donors. The problem is we have a glut of patients with heart failure, and in the developed country, this is a growing problem, and it's only going to get worse. So we need to figure out a better way to utilize the organs we have and to expand our donor pool. So the topic now is ex vivo perfusion and warm ex vivo perfusion. This is not a new topic. This is Oscar Langendorf's schematic from 1895, more than a century ago, showing us how to preserve a donor heart on an ex vivo system, and labs all around the world have used this now for generations to study the heart and ventricular mechanics. But the early use of these type of systems in the pioneering days of transplant didn't go well. They were associated with organ injury, myocardial edema, and air embolism. So we went to this, which was much simpler and much cheaper, and of course this is cold storage, and cold storage does a pretty good job. With cold storage, we can extend the ischemic times pretty safely out to about 6 hours, maybe a little longer in pediatric patients, and this has been the mainstay of how we've preserved organs in the heart transplant arena since that very first transplant up until very, very recently, as you've heard. But the problem with cold storage is, again, it limits the amount of time that we can keep organs safe outside the body. And while we can go out to 6, sometimes longer, you can see from this UNOS data that when that ischemic time approaches just 4 hours and gets beyond 4 hours, there is a measurable decrement in survival of patients at 5 years. So ischemic time does matter, and perhaps cold storage is not optimal. So out with the new, back in with the old. Here's warm machine perfusion. This is the Transmedics device that you've heard all about now. And this is a really nicely engineered device that's been developed over about the last 20 years. It's a platform that can preserve both livers and hearts and lungs. And this is the module for preserving and assessing an ex vivo heart. I thought someone might have shown this schematic by now, but they hadn't, so I'll show it. This is the blood is delivered to the ascending aorta. The venous return comes back to the right ventricle. The superior and inferior vena cavae are both sutured closed so that all the blood, the coronary blood that's returned to the right side, is pumped out of the pulmonary artery, which is connected to a cannula, and we have a flow probe on that, which gives us a very accurate measure of coronary blood flow. The left atrium is completely open with a vent catheter inside. So the left ventricle, as you've heard, is perfused in an unloaded condition. The right ventricle is perfused in a partially loaded condition. It will pump the coronary blood flow, which is around 800 to a liter a minute of blood. So you do get some assessment of right ventricular function visually in a partially loaded state. We can both measure and modulate heart rate, aortic pressure, and coronary blood flow, as you've heard. But what we use to assess the heart is a surrogate. It's aortic and venous lactate levels. And why is that helpful? Well, we've known since the 1960s that as opposed to other organs, the heart actually utilizes lactate as an energy source. And in the normal situation, the arterial lactate level going into the heart is actually higher than the venous lactate coming out of the heart. So again, the heart will utilize lactate as an energy source. And it was realized way back then that when you saw the reverse of that, when the heart became a lactate-producing organ, that was a sign of pathology. So in this particular paper, if they took normal patients and rapidly paced them, they continued to utilize lactate. If they took patients with coronary disease and rapidly paced them, you saw that those hearts became lactate-producing organs. So we can utilize that same concept in looking at lactate in our perfused hearts, and when lactate is going up in the system, that's a sign that the heart is not doing well. So the advantages of ex vivo perfusion potentially are they could expand the donor pool by both extending the safe out-of-body time and allowing us to take organs from further away, but also they give us some ability to evaluate the donor organ prior to putting it in. Importantly, this type of system can also remove the urgency of travel. Our procuring teams are often running around in the middle of the night, often in foul weather, and there have been historical cases where procurement teams have actually perished from plane or helicopter crashes, and that has to do with the urgency that we feel in moving those organs around. It also can remove the urgency of the cardiac explant. Our recipient patients are sicker now than they've ever been. They've often have multiple sternotomies. Most of them now have implanted mechanical support, so having to do those operations in a hurry can be anxiety-provoking, especially when you have a heart waiting for you on the back table. So if we could do that in a more timely, controlled fashion, that would be certainly advantageous. Potentially, we could use such a system to resuscitate hearts by delivering pharmaceutic agents. Even gene therapy has been tried in the case of lungs. Could this be done with hearts as well? That remains to be seen. And we can, in fact, do angiographic assessments of these hearts in cases where they're procured in hospitals that don't have coronary angio capabilities. Well, the OCS system's been trialed in the PROTECT as a phase 1 safety trial and now in the PROCEED 2 trial, which was a phase 3 trial. It was published a few years ago in The Lancet. This was a randomized control trial randomizing the OCS system to cold storage in standard transplant practice. It's approximately 65 patients in both arms. And what you saw, as you would expect, the total preservation time in the panel on the left was higher in the organ care system. However, the cold ischemic time was significantly lower. Those hearts essentially did the same to cold storage. So this was a non-inferiority trial. There was the same incidence of graft failure, which was low, and left and right ventricular dysfunction, which was low in both groups. So what we concluded from that was warm ex vivo perfusion can be safely applied to standard heart transplantation practice. However, it's considerably more expensive and requires additional technical expertise, as you've heard. And the question then was, could we do this could we use it in a different fashion, not in lieu of cold storage, but perhaps to take organs that we wouldn't otherwise utilize? So the questions really are marginal donors preferable to bridging mechanical support? So if you could avoid an LVAD, would that be worth using a marginal donor? Is a marginal donor preferable to waiting longer on an LVAD? Patients on LVADs have not insignificant yearly risk of stroke or other bad things happening. So is utilizing a marginal organ in that situation beneficial? One of the risks, of course, of utilizing a marginal donor is those organs may not be well preserved in simple cold storage. So could machine perfusion do a better job? And can we do this to use these marginal hearts more safely? This is the group at the Brompton, published a few years ago in the Annals, and looked at 30 of what they called high-risk donor organs. They discarded 4, but of those patients that were transplanted, they were all 96% were alive and well in midterm follow-up, 92% with normal function. So it appears that we can do that in selected patients, and that was the impetus for the EXPAND heart trial, which we participated in, which is a non-randomized prospective trial utilizing this system to evaluate marginal donor hearts. Hearts are marginal based on expected ischemic time beyond 4 hours or or some criteria of the donor heart, could be LVH, could be low EF, could be some degree of coronary disease, et cetera. Just completed enrolling 75 recipients. The data is being presently analyzed. The primary outcomes are 30-day survival with absence of primary graft dysfunction. As Chris mentioned, we had 11 attempted runs. We put 10 of those on the device. One was turned down because of the appearance of the heart in the chest. Of those 10, we discarded 3 of them, which we considered somewhat of a high rate. 2 of them were because of unfavorable lactate trends, and one of those was because of poor right ventricular function on the device. As I mentioned, you can get a visual assessment of a partially loaded right ventricle. Our practice was to consent pretty much our entire list, and the majority of whom wanted to participate, so that's the age of our recipients is pretty much a standard age in our transplant practice. We evaluated donors ranging from ages 18 all the way up to 56. The average support time was just over 5 hours, a little bit longer than the average support time than those that we rejected. It takes generally a couple hours before you know those hearts are going to be okay, and it's at that time that the recipient operation begins. So in the case of an LVAD explant, for example, that can translate into a pretty long time on the device. Of the hearts that we accepted, the arteriovenous lactate was generally below 3, and of the 2 that we rejected, it was above 5. This is, like you've seen, a video of what the heart will look like soon after it's perfused. It will generally start to beat quite vigorously. These hearts are coming out of the chest in a controlled fashion, so dissimilar to a DCD heart that might take a little while. Again, as you've seen, what we have over time is coronary blood flow, which we can modulate. We generally don't modulate it as long as the heart's doing well. In our experience, what we generally find is that the arterial, that the system lactate will rise for a couple hours. It will then generally plateau, and in the hearts that are going to be good, it will remain stable or decrease over time. And as Peter McDonald's group published this showing that these hearts can be instrumented and fairly easily, you can do selective angiography of the hearts while they're on the machine if you need to. And in this case, this donor heart had significant coronary disease, and of course that heart was rejected. We've not done this clinically, but we wanted to look at how we might use this system to utilize DCD hearts in our region. So with the support of our New England Organ Bank and Transmedics, we looked at 6 DCD human hearts in our region and put them on the device. We used a little bit of a modification to put a pressure transducer and a balloon expandable catheter in the left ventricle, suture to the mitral annulus, so that we could obtain quantitative data of left ventricular function. We were able to get data like this where you can see the developed pressure of these ventricles would improve over time, and we can get both systolic and diastolic properties of the ventricles, and in hearts that were doing well, generally those parameters would be within normal limits. Here's an example of a heart that doesn't look quite as good. This is the left ventricle over on the right side. The hearts are rotated somewhat on the system. And here's one that we weren't very happy with the visual appearance. This is our 5th heart. There's quite a learning curve to doing this, and by the 5th heart, we thought we were doing pretty well there. And here's the 6th heart that visually looks even better. But this particular heart, for unexplained reasons, had rising lactates the whole time. So by present criteria, we would not have used this heart, although visually it looked quite vigorous on the machine. So our experience with looking at DCD in sort of a preclinical fashion using human hearts, I would say, is mixed. It certainly can be done, but the results are not universally good. So in conclusion, I would say that warm ex vivo perfusion can preserve donor hearts for extended periods. It gives us some ability to assess the suitability of marginal donor hearts. Can we safely expand it to include DCD donors? We've heard that you can. and that's exciting and something that's not really been done in this country, at least in adult patients in the modern era, but I expect will be done in the next 1 to 2 years. Will perfusion systems prove safe and effective? I think that remains to be seen a little bit, and can we afford it? That definitely remains to be seen. So this is taken off the Transmedics website, and 3 of their claims that this system can increase transplant volume. I think that's true. I think that we've shown that you can, and others have shown that you can. Can it improve patient outcomes? I think it probably can, because you can have more access to hearts and patients that need it. And they also claim that it can reduce cost. Well, it certainly introduces a lot of cost. And one of those claims is that perhaps by avoiding the need for bridging mechanical support, giving more access to organs, it can obviate some of that other cost. So I think those are possibilities, but some of them, again, remain to be seen. And this is just a snippet, fairly recent, that I found on the internet, just announcing another $50 million round of money that Transmedics was able to collect for further development of their product. And I've heard numbers in excess of about 4 times this that's been sunken into this technology. So there's a tremendous amount of money that's been invested in this system. Again, it's not just for hearts. It does work for other organs, but this is a company that's going to need to make this money back. And heart transplantation is not a big operation. It is a profitable operation for most hospitals, but the packs for this are about $45,000 a piece. If this were to get approved, it's a single vendor without any real competition, so I think it's possible that number could go north. And I'm not sure how we're going to pay for it, and I think that's a very open-ended question. So that's all I had for you. I want to thank you all for your attention, and I guess we'll be happy to answer questions.
So I wanted to thank all the speakers for a terrific session. We can now begin our panel discussion mode. So all those folks who had questions in the audience, please come up and ask your questions. Monty Donishman.
Monty Donishman from Duke. My question's for Steve Suey, Papworth. First of all, Papworth always at the cutting edge of heart transplant, and they continue to be. It's amazing. But so how did you navigate we're having a lot of trouble, at least within our region, trying to even convince the OPOs to allow us to try this. I saw, in Boston, they were able to at least allow to do it experimentally, but our OPOs are very much adamantly against even considering DCD heart. So how did you navigate the marketing around this as the first question? The second question is, how long do you keep them regionally perfused? What's your typical time, and what metrics do you use to decide to come off regional perfusion? Thanks.
Thank you for those questions. Well, one of the reasons why it took us so long to start a clinical program was exactly getting regulatory approval from the Transplant Authority, from our hospital institution review board, and so on. I think looking back, we were probably ready to launch the clinical program back about 5-6 years ago. But it took us 2.5 years to actually get all the different bodies to allow us to go ahead. In some ways, we were fortunate to have the document that I showed you, the Code of Practice for the Diagnosis and Confirmation of Death, which happened to be published by a totally independent academy. And this academy has got a very long history in the field, in that it was in 1976 when they first published their Code of Practice and Guideline for Diagnosis of Brain Stem Death. And because it was independent to any transplant group, or indeed our group, we just went along to all the different authorities and said, look, this is the framework, and this is, as I said, legal and ethical framework within the UK. Abdominal teams were already doing abdominal NRP, and this is an extension to other organs. And also, what is interesting is that we were getting increasing requests from donor families, from DCD donors who were saying, well, the abdominal organs are being donated and the lungs are being used. Why aren't we able to donate the heart as well? So it was really a number of factors that eventually gave us the permission to go ahead with the clinical program. The second question is about the duration of the normothermic regional perfusion. So how long and how do we decide how long to keep donors on NRP for? Well, the median duration is about 45 minutes, but we don't have a set time. Usually, by the time we get onto NRP, there's been a 12-15 minutes of downtime. And once we get onto NRP, most donors are completely vasoplegic with no vascular tone. When you look at their acid base, the hydrogen ions probably in the 50s or 60s, and lactates over 10. So that's the normal picture that we see, and it usually takes a good 40 to 60 minutes to optimize the biochemistry. If necessary, we will put a hemofilter on, give lactate. In terms of vascular tone, that's actually one of the challenges, because what we don't want to do is to use too much vasoconstrictor, which could end up compromising organ perfusion. So in addition to tying off the 3 arch branches, we would very readily and regularly tie off the external iliacs as well. So literally, it is just perfusing all the thoracic and abdominal donor organs of interest, and you exclude the rest of the circulation. So once we've actually achieved biochemicals of normality, we would then attempt to load the heart under transesophageal echo guidance as well as right atrial pressure guidance to try and wean these hearts off NRP, so that it is actually becomes mechanical MRP into biological NRP, basically, the donor heart and lungs, oxygenating and perfusing the other abdominal organs.
Hi, it's Marcelo Cipel at Toronto. So I'm not a heart transplant surgeon, I'm a lung transplant surgeon. And so I'm first interested to know what's happening with the lungs from, both NRP or direct procurement case that, talking to the Australian guys, I know they have lost a few lungs even during, DPP because, rushing, causing injury in the lungs or hyper perfusion as well and pulmonary edema. So that's my first question. The second question is, I think NRP makes a lot of sense, and my question to you is, what do you think ex vivo perfusion give you in terms of information more than what you already achieve during in situ perfusion?
Okay, thank you. First of all, I know it's semantics, but we try not to use the term ex vivo because these donors are dead, so they're not alive. We tend to use the term ex situ or machine perfusion. Now, I think when we want to look at donor lung utilization, it actually varies from country to country. The Sydney program reports about 70% of their DCD donor, and they've done 23. About 70% of their donors, they were able to take lungs and transplant them successfully. In UK, DCD lung use is about 8% of all the DCD donors. And in our series, we've used about 12% of lungs from the DCD heart donors that we have. You see that we've got really a very high a percentage of potential DCD heart donors meeting criteria, which is unusual. And the reason for that is actually in majority of those donors, the lungs were in such poor shape that as soon as we withdraw ventilation support, they become hypoxic and rest. So this almost 70% of DCD donors resting is a very high percentage, but that also probably explains why a lot of these donor lungs were actually turned down for transplantation before withdrawal of life support. And that's probably why we've got quite a relatively low DCD lung use rate in the UK. I can't remember, was there another question?
I think you got it.
I got it.
Yeah.
Okay.
Yeah, I think was how much do you think the I would say the ex situ organ assessment adds on top of NRP?
Well, I think the organ care system obviously is the only commercially available device available for donor hearts. perfusion right now. It's allowed us to gain a lot of experience over the last 12 years. We were one of the first centers to be using it back in 2006 in the PROTECT study. But it's got its limitations. They initially had a working mode. They withdrew the working mode. Now we're trying to put it back in some form or another. We know that hearts that have been perfused for much more than 4, 5, 6 hours will start to get edematous. So it is somewhat that we need refinement. We really need further work to get an improved system. And in time, if we can perfuse donor organs in machines for 12, 24 hours, like in lungs, then it really opens up all the possibilities of biologically manipulating these organs before you transplant them.
What is the longest heart that's been
Well, the
supported?
longest we've done
Yeah,
it was 7 hours, 20 minutes, and that heart was pretty edematous by the time we took it off the system. The longest reported in literature, I think, is 10 hours, nearly 10 and a half hours.
Australia.
And as far as I know, the recipient was put on ECMO for a period of support until the edema settled and did well afterwards.
Is that for just DCD?
No, these are DBDs. So our longest DCD was 7 hours, 20 minutes, but the longest in the literature, 10 hours something, was a DBD heart.
Ali Gotz at the University of Miami. Thank you so much for this excellent session. A question I want to have was, when you have the donor and you reintubate the donor in a in a DCD session, when you reintubate the donor in a DCD session, do you ventilate one time before clamping the carotids, or do you ventilate afterwards? And question number 2 would be, considering the fact that Transmedics is currently not FDA approved for DBDs, do you think that the lactate measurement is crucial for your assessment with your experience? Because the next would be that Transmedics would go for approval for DCD at one point. Do you think it was crucial for you as far as the lactate consumption was concerned?
So in terms of intubation, yes, we try to intubate the donor as soon as possible, but that's for airway protection so that the donor does not aspirate any gastric content. In the UK, there's a very clear guideline saying that we must not inflate the lungs for a minimum of 10 minutes from the confirmation of death, or we can ventilate lungs after we clamp the aortic arch branches. So those are the sort of guidelines that we have to work with. In terms of lactate assessment, I think Papworth is in the bad books of Transmedics because we've been challenging that concept with our experience on the DCD hearts. I think the trend data and the upper limit, the ceiling of 5 overall, the ending lactate of 5, these have been derived from DBD heart experience. And we would say that these are very sensible, but you would almost never get a DBD donor that you take blood from with a lactate of 10 or 12 to begin with. So, as I mentioned already, a lot of the DCD donors, when we drain blood from them and prime the circuit, the starting lactate is 8, 10, 12. So the upper limit of 5, I don't think applies anymore, because there have been a good number of DCD hearts that we took where they sort of trending downward of lactate, and the ending lactate is still 7, and we transplanted them successfully. So that's number 1. Number 2, in terms of the trend, I think probably because with the NRP program, we've been able to assess these hearts with echocardiogram as well as Swan-Ganz catheter. That gave us confidence that these hearts have fully recovered functional contractility and output. So there have been a few occasions when there's a rising lactate trend once we took the hearts and put it on the OCS, armed with the confidence of the functional assessment information. We went ahead and transplanted these hearts, and they still did very well. So that's why in the last couple of years, we've started to challenge the dogma about trends and the threshold in the area of DCD heart assessment on the OCS.
Marian Zembala, Zabrze, Poland. Thank you so much for a good session. More practical question. In this expanding donor criteria time using the DCD Transmedic, how often in your clinical scenario you have the primary graft dysfunction, and how affect your early and late outcome using the ECMO and all the other support? Perhaps the question to the leaders of Papworth, Penn, and Harvard will be useful for us. Thank you again.
Very good question. I actually skipped through that slide very quickly on outcomes. So about 15% of our DCD heart transplant required a balloon pump, and if I remember correctly, 3 of the 44 required ECMO support. In the end, 2 of the grafts out of the 44 did not recover, and in fact, both patients died beyond 30 days. On occasions, what we find, which it sort of surprises us, is that it sometimes the heart seems to be a bit stunned after transplantation, and so we very readily support it with balloon, but sometimes just 6 or 8 hours later, these hearts are pumping with index of 3 or 3.2, and we've often been able to take the balloon out within 12 or 24 hours, which is somewhat different from what you would see in a DBD setting. But overall, the rate is probably no different from the DBD experience. And when we've also done 1-year echo and MRI studies of all the DCD hearts that we've done, and the 1-year cardiac functions look very good in the survivors.
Thank you.
You have a question? Let me pivot a little bit to Dave Morales. Dave, one of the things that I've noticed at least in the adult congenital patients that are coming for VADs, is that there's a lot of discussion around electrical problems, and that the EP people, will continue to work on their electrical system. Is there, and in all inevitably, you wind up with someone who's really pretty sick at the end of all that. What are your thresholds as far as how much do you go down that pathway of trying to optimize them electrically before thinking about advanced
there's
therapies?
more and more biventricular pacing that they're trying to do, especially with the single ventricles. There's been some success, but not a lot, I would have to say. And I'm, again, like you said, the problem is you keep limping them along, and then, the time everybody says, okay, now it's time, it's too late. And we're working on, we have this interactive learning consortium called Action, and we are putting out a paper of when to refer Fontanes for heart failure, and when they should be maybe starting to be co-managed, because there are a lot of them that are out there, right? And they, they're deceptive because their changes happen over time. They've always been a little cyanotic. They've always had a little bit of this or that, and people keep limping them along. But the problem is, a lot of them we're talking about, they're older teenagers or in their 20s. They compensate very well, unlike our adult colleagues. So by the time they actually present with bad symptoms, they're far down, and they have bad GFRs, and they have bad livers, and for people who have done Fontan transplants, it's a haul. A lot of them, like you said, they limp along, and they've had 6 or so operations. And I was just thinking your device would be great, right? Because that's, doing a 7th, resternotomy, dissecting all of that out, and then having to reconstruct a lot of that. I wish we could just have we tend to have long bucket times when we do that. So, and I'll tell you that kid that with the hypoplast, I have no desire to ever operate on that kid again, right? So he was a 7-time redo, and his aorta is 9 millimeters, right? So you can see the blood swirling underneath it because it's homograph material. So I did everything with the heart beam because I didn't even have a clamp that would go across all of it. So he would need circle rest and his vessels. So I hope he lives with that device for years.
Steve, you want to add something?
Yeah, David, really enjoyed your talk. in the sort of adult setting, when in Europe we've used a lot of, for example, hardware as BIVAD, but we've noticed quite a high instance of problems with pump thromboses on the right-sided pump, and not infrequently the right-sided pump becomes sort of decommissioned. Have you seen this similar problem with using the pump on the venous side in your patients? Because you wonder whether this is actually true in situ thrombosis from the venous blood, or whether it's actually ingesting preformed thrombus from the venous system of the patient.
Yeah, to be honest, I don't believe in RVADs and Fontanes. I think it's not, physiologically doesn't make sense to me. So forcing blood through an abnormal vascular system, right, doesn't work. And isolated especially, because almost all of the Fontanes have restrictive physiology on the left side. So, you know, I know there's a lot of work being done, but even the people doing work have now suggested that really their devices should be used to turbo your Fontan so you avoid the situation. And so if I had a Fontan that, you know, who you couldn't support with just with a systemic ventricular system, I would use a total artificial heart.
Makes sense.
Yeah. And there are issues with that, but I think there are implantation techniques that, that will allow you to use it.
I think we're approaching the coffee break. We have time for one last question. I guess maybe my question would be for the PGD. I mean, really, shouldn't it just be ECMO? And is everything else really just a waste of time and money?
Yes.
All right. Good. Good break.
I think
you want to amplify?
I think you've got to look at really how much residual activity there is in your failed heart. If it is actually sitting there doing nothing, then just using ECMO means that you will have complete stasis of the ventricles, complete stasis in your pulmonary circuit. And if you have pulmonary circuit, pulmonary vasculatory thrombosis is game over. So in those cases, I think having BIVAD and to wash your ventricles with ventricular cannulation is important, because it gives you the chance of an acute retransplant, if nothing else.
That's a good thought. Okay, I just want to remind everybody that our lunch symposium speaker is Dr. Bruce Reitz, and for many of you know who he is, but he's truly a master surgeon, and I think it's an incredible opportunity. So make sure you take advantage of that and see you guys at lunch. But otherwise, we'll go to our coffee break, and then we'll come back on our session, which should be fantastic on ECMO. So see you shortly. Thank you for everybody's attention.